What is metatomidine and how does it impact my practice in dentistry?
Find out today on Medical History Mysteries.
Hey, everybody, welcome to Medical History Mysteries. I'm Pam Maragliano, Chief Editor for Dental Economics, and with me, as always, my buddy Tom Viola. What's happening?
Good to see you, Pam. How's things?
Things are well. This always happens. So I just went to the veterinarian's office and, Senorita got checked out. Everything's good. Don't worry, anybody.
Awesome.
But it always gets me thinking about vet medicines that can be used on humans and vice versa. Now, we know that there are some medications that both animals and humans could both use, but then there's some that are intended for maybe veterinary uses, and maybe we abuse them as humans. So let's talk about metatomidine for a second.
Yeah, for a while I was involved in veterinary medicine and understanding how veterinary drugs work. And, if we haven't spoken about it recently, Pam, I know we've spoken about it before, where a lot of fentanyl that's available on the street now is laced with xylazine. Xylazine is a veterinary anesthetic that is used, again, in veterinary medicine it can be used as a tranquilizer. It could be used as an anesthetic agent. It's got multiple uses. It's mostly a tranquilizer. Okay, fine. What the heck would that be doing in xylazine? So if I sell you a dose of fentanyl with xylazine mixed in it, you're going to be under the influence of both drugs. Now, the xylazine lasts a lot longer than the fentanyl because xylazine is a veterinary anesthetic designed for large animals, equines, so horses and bovine cows, right? So it's for large animals. If you use it in human, that's, a third to or a fifth of the weight of a large animal. Obviously, it's going to last a lot longer. So the xylazine lasts longer than the fentanyl. And that means you're under the influence of both. The fentanyl runs out. You're still under the influence of the xylazine, let's say another 4 hours. By the end of that next 4 hours, when you're out of, finally out of or not under the influence of the xylazine anymore, well, you've been in withdrawal from the fentanyl for 4 hours. So you're desperate now, ravenous for another dose of fentanyl, which I'll happily sell you with more xylazine and trap you in this 10-hour prison forever. So unfortunately, there was no way to know that you were using fentanyl that was mixed with xylazine. If you've seen video of this, and I'm not going to point out in particular where to go find them, but if you view videos of people who are under the influence of this drug, you'll see them in videos of like the Kensington section of Philadelphia, San Francisco. It's such a powerful muscle relaxant that you will see people bent over in half and still maintain their balance. I probably could never do that myself. I could never literally fold myself as some of these unfortunate folks do. So, okay, xylazine is an issue. Guess what? We make tests available now to the general public where you could test your sample of fentanyl to see if it contains xylazine. So what's the next step? Come up with yet another drug that doesn't have these testing strips, and that's metatomidine. Now, metatomidine is used in veterinary medicine as well, but the problem is the metatomidine that is in this fentanyl is a racemic mixture of two different kinds of metatomidine. Dexmedetomidine, which is for human use, and levo, which is not. And unfortunately, you don't get to choose which one you get, and it can have some serious adverse effects in humans. But the bottom line is it's being used in place of the xylazine for the same reason, to keep you in this tranquilized state so that, again, when it finally wears off, you've been in withdrawal for the fentanyl and you want to buy more.
Whew, wow. Okay. So I guess they'll never stop coming up with ideas of things to use.
Oh no, I would, if someone said to me, well, I'll pay you $1 million to go buy some fentanyl on the street and use it, that would never be enough for me because of all the different potential adulterants in fentanyl. So you've got, in addition to the xylazine and the metatomidine, you've got things like, uh, you know, um, what's the one that comes to mind almost every time I say it? And I almost don't want to say it. Kratom. Okay. Kratom or kratom, depending on how you pronounce it, is an opioid that's also a stimulant. And so kratom is mitragynine in its natural form, but when it's metabolized in our liver, it becomes 7-hydroxymitragynine, which many people just call by the street name 7-hydro. So that's mixed in with your fentanyl. That increases the addiction. That increases the effects including respiratory depression. And then you've got everything from synthetic cannabinoids that are like synthetic THC. You've got MDMA, which is now being put into fentanyl. And some of these adulterants are finding their way into marijuana, cannabis. So all of a sudden, everything that you're buying is almost this case of one-upmanship. Like, I'm going to sell you cannabis, but mine has this. I'm going to sell you, fentanyl, but mine has this. And while you might say that's horrible and this shouldn't happen, the problem is it increases the allure for patients who use these substances because, quite frankly, they don't know what they're getting and they like it. The fact that they don't know what they're going to get is the allure. And so that's opening the market to more and more of these synthetic opioids and veterinary medicines that don't belong in humans, but end up becoming part of it because, again, it increases hey, I want to try this and let's see what happens.
What's the likelihood we're going to run into a patient that's on something like this? It sounds like they would be pretty debilitated if they were taking it. And how do we have this conversation with our patients?
I get this a lot, Pam. I'm not going to lie to you. People who watch our videos sometimes say to me, I like what you have to say, Viola, but really, what's the likelihood? Come on. I don't have patients in my rather high-end practice that are going to be using these substances. All I can say respectfully is I beg to differ, especially kratom, because kratom is a plant that you can grow in your own house, pick your own leaves, crush them, roll them up, smoke them, and you're under the influence of kratom. Now, you could do that, but you could just buy it yourself. And if I told you, because I've worked with law enforcement long enough to know how many people who are, let's say, potentially, higher end clients who've been arrested for buying kratom, it would shock a lot of people. So my idea is anyone, and there's no age group, there's no income level, anyone could be using these substances and thinking, well, no one would ever suspect me. And unfortunately, that impacts us in dentistry. So it's important, as we've said 1,000 times, you and I, to take the complete and accurate medical history, ask the tough questions, and document the answer. Do you use substances? And if the patient says no, that doesn't mean you don't write anything down. It means you write down patient denies the use of substances. It's also important to write down your impression though. So you could say patient denies use of substances, but my impression indicates they may be. And that way, at least you've documented that you've asked the question and that you have your suspicions. So later on, if that comes up as an issue in litigation, let's say, your notes are complete versus incomplete.
How would that impact our dental care if you are suspecting that somebody's taking something like metatomidine?
So the problem is it becomes unpredictable as to how they respond to things like opioids that you may prescribe for pain, nitrous oxide that you may use for sedation, as well as benzodiazepines if you're going to do conscious sedation. So, for example, let's say you did IV sedation. If you're one of the docs who does an IV sedation in the office, they may fall deeper into sedation than you would expect them to, and now it becomes a life-threatening emergency. So, their airways compromised where you didn't expect it before. So that's why you've got to ask these questions and be ready. And if your spidey sense is tingling that, hey, and they're saying no, but I think otherwise, then be conservative in your measures because, or simply reschedule, but with a good and clear understanding to the patient as to why you are. Look, they may get annoyed, they may be upset. They may even resent the implication, but if you've got enough evidence on your side to say, this is why I think the way I do, then you're better off not taking the chance on a medical emergency that might end up in a fatality versus just saying, look, I don't feel comfortable doing this procedure today.
I also think this is a conversation that should be had among the dental team and the practice owner ahead of time, having protocols in place. If you have a suspicion, how you should act, what you should do, what you should say, and be prepared ahead of time so that you're not sort of making a game time decision, hoping for the best in the moment when you're probably feeling uncomfortable, unsure what to do, unsure who to talk to, and how to have that conversation in a private manner.
I think if you're the supervising dentist slash practice owner, either one. I think if you're the person who is on point as the authority in charge at that moment, that responsibility falls on you. So, with all due respect, don't leave it up to your staff to have that conversation. You've got to be intimately involved because you're the supervising dentist that day. That responsibility falls on you. So train your staff to come to you with issues or suspicions so that you can vet them and get to the bottom of whatever issues there are. And I would make it a point of saying, I'm no lawyer, so don't take this as legal advice, but I would make it a point of saying, look, if you're using substances, anything you use can interact with anything I'm going to use today, and that can lead to harm up to and including potentially your death. So if you can't be honest with me about what substances you're using, then I'm going to respectfully decline to treat you today. That's if you have a very strong suspicion. But if you don't, the best you can do is ask, get their answer, and document it. Because if it's in the chart, it lives forever. If it's not in the chart, it never happened.
I think we increased more awareness this week. I know last week we did as well. I think this week is something that it's a timely topic. We should be having this conversation and don't wait until you're in the moment. I think it's important to have a plan, have a protocol, know what to say, even role play and work this out amongst yourselves so that you're ready to go and ready to have this conversation with whomever you end up having it with, whether it's somebody that you sort of suspect or somebody that comes as a complete surprise to you. This way, you're prepared.
It's a tough conversation to have, but I'd rather lose a patient who gets annoyed and walks out than lose a patient because they passed away in my chair. And that's how I've always looked at it.
Abso-freaking-lutely. All right, everybody. For Medical History Mysteries, we will see you all next week.
Take care, everybody.